appreciate you guys giving me the time to come give you a talk. And obviously, I think it's a panel discussion, so we'll definitely address any and all questions in the chat box at the end. And let's get started. So I think Linda mentioned kind of have a talk about neuroanatomy and ischemic stroke, and I want to focus obviously on the definition of ischemic stroke, some of the causes, but then also kind of take some time to go through neuroanatomy, mainly neurovascular anatomy, starting from the aortic arch, going all the way up into the circle of Willis. So as mentioned, kind of we'll start with talking about what the difference between TIAs and strokes are, and then kind of focus it's almost more of an anatomy lesson, looking at anterior circulation syndromes compared to posterior circulation syndromes, and how the blood supply dictates the deficits that we'll find. So there are about 5.5 million new or recurrent strokes occur annually across the world. And unfortunately, we know this is a significant portion of morbidity, as 50% of patients, 50% of sufferers remain permanently disabled. Some quotes from kind of an old stroke update in the AHA. About one stroke occurs every 40 seconds somewhere in the world. One stroke causes mortality every 4 minutes, and about 4.4 million disabled stroke survivors. And so as we see here, as we see here around the world, obviously stroke is quite prevalent everywhere, and the mortality rate is quite high. So we know stroke can be caused by numerous causes: lacunar strokes, cardioembolic, atherosclerotic, cryptogenic, as well as our hemorrhagic variants, things like subarachnoid hemorrhage and ICH. For today's talk, we're primarily going to focus on atherosclerotic cardioembolic strokes, not on the lacunars, not on the hemorrhagic strokes, but primarily these two topics down here: atherosclerotic and cardioembolic. So before getting into the big strokes, I think it's important to think about risk factors. So I think to break them down, I think it's good to think of them as non-modifiable and modifiable risk factors. So non-modifiable risk factors being things like age, your sex, your ethnicity, hereditary factors like genetics, and of course your modifiable risk factors, things like hypertension, diabetes, hypercholesterolemia, cigarette smoking, physical inactivity, and this includes things like obstructive sleep apnea, as well as obesity. And in terms of the workup, so both in patients that come to the office with TIA or history of TIA-like symptoms, or they present in an acute fashion, I think it's important to understand what the stepwise process to work these patients up is. One is, if we break it up into different forms of stroke, it may dictate various imaging studies. But generally, you want to understand both what the cardiac history is, what the neurovascular anatomy is between the neck and the head, and then also if there is some discrepancy or between the imaging and the clinical findings, then you may need to do a much higher level test, something like an angiography. So as mentioned, so typically a cardioembolic stroke, the workup requires an EKG, transthoracic echo, obviously to see what the etiology is. Is it a valvular lesion? Does the patient have a PFO? And then moving up to the neck, want to look at a carotid duplex. Is there atherosclerotic disease in the neck that is causing them to have TIAs? Or is there already some amount of stenosis that requires intervention now? And of course, more intracranial stenosis, and this could be a cause of things like lacunar strokes, where is there something that these patients need to be on antiplatelet long term? So just things to kind of keep in mind. So now thinking about TIAs and ischemic strokes. So interestingly, the definition of TIA came actually about in 1975. So the Ad Hoc Committee on Cerebrovascular Disease in 1975, from essentially an arbitrary statement, stated that defined ischemic stroke as cerebral dysfunction of ischemic nature lasting no longer than 24 hours with a tendency to recur. And we know that these patients that they do get a TIA, the risk of getting a full stroke or converting to a stroke is very high. There's quotes of as much as 10% in the next 30 days, or even 10% in the next 3 months. So in patients that do present with TIAs, it's essential to, one, pick it up, but then two, work them up and evaluate them to make sure that we don't miss that stroke that occurs shortly thereafter. So what are the major types of cerebrovascular disease? So obviously we talked about TIAs, but also brainstem TIAs, lacunar strokes, and also hemispheric. And this talk is primarily going to be focusing more on the hemispheric strokes, hemispheric anatomy. And then perhaps subsequent talks can focus more on lacunar anatomy. So looking at neurovascular anatomy, so this is just, I'm sure a lot of you have seen this, but this is a conventional angiogram looking at the aortic, looking at an aortic arch injection. And you can see here the subclavians bilaterally, the carotid arteries going up into the neck, and then also the vertebral artery that comes off the subclavian. They're supplying the posterior circulation. So when we think of the aortic arch, I think it's important to understand its anatomy. And so this is kind of a nice diagrammatic sketch of the aortic arch. And as mentioned, it is numbered. Sorry. So the main branches of the aortic arch are primarily the innominate, the brachiocephalic, right subclavian, and the right common carotid. And then the right brachiocephalic will then therefore break into the right vert and giving off subsequently the right ICA as well. So here we can see in number 4 is the right vert, number 5 being the right carotid, and you can see here the left common comes off directly off the aortic arch. So the right subclavian gives off the right carotid, and the left carotid comes right off the arch. Here's another schematic view. I think it's a little bit more easy to understand, I think. And here you can see again, so off the aortic arch, you have the brachiocephalic, which then branch off into the right subclavian and the right common carotid, followed by the left carotid, as well as the left subclavian. And the vertebral arteries will come off the named subclavian arteries. And as you see here, the vertebral arteries will then merge to form the basilar, which then gives off the posterior circulation. And then the internal carotid arteries will then the common carotid arteries will then divide into an external branch and internal branch. External supplying primarily the neck and the face, and the internal, of course, going on into the intracranial circulation and providing the anterior circulation of the circle of Willis, which we're going to get to next. And so this is a nice 3D rendition of a CTA of a carotid. And you can see here, here's the common carotid, this big pipe here that's running anterior to the vertebral spine. And you can see it breaks up into an internal circulation as well as an external circulation. And then here you can see the vertebral artery, which is running through the vertebral foramina of the cervical vertebrae. It usually enters around C6, and then runs through the vertebral foramina up until the posterior circulation, where it merges with the other vertebral artery and enters intracranial circulation. So as mentioned, we already kind of talked about this, but the origin of vertebral artery. So there's a right common, comes off the arch, and then also distal subclavian. And here's an MRA rendition of essentially the same thing. So here's your carotid artery coming up. It's splitting off into an external carotid as well as an internal carotid. External supplying the face, neck, and then internal, of course, going into the intracranial circulation. And just kind of not to go too much in the weeds, but both the external and internal carotid have numerous named branches that come off. The external carotid has eight named branches that come off the external circulation, starting with superior thyroid, ascending pharyngeal, lingual, facial, occipital, the posterior auricular, superficial temporal, as well as the internal maxillary artery. And they essentially, as mentioned, they supply the neck, they supply the face, they supply the orbit, and they have numerous anastomoses with intracranial branches kind of deeper in the orbit and deeper at the anterior skull base. This is kind of nice, just kind of pointing to where these arteries are on the takeoff. But here's the superior thyroid. There's the ascending pharyngeal. It's lingual, supplying the tongue area, facial, supplying kind of the inferior jaw and going to the face. The occipital artery, which goes behind the ear. Posterior auricular, which also goes behind the ear. Superficial temporal, which runs right in front of the ear, as well as the maxillary artery, which goes up into the upper part of the jaw, as well as kind of deep into the anterior skull base and the anterior cranial fossa. As mentioned, the internal carotid artery also has named branches. It has seven named segments, and each segment has branches typically. As you can see here, the odd numbered segments do not have branches, but the even numbered segments do have branches. So the named branches of the internal carotid artery circulation are primarily cervical in the neck, petrous through the petrous bone, the lacerum segment. 4 is the cavernous segment, which is what we find in the cavernous sinus. 5 is the clinoidal segment, which runs right around the anterior clinoid. 6 being the ophthalmic segment, which runs behind the eye. And 7 is the communicating segment, which then is once you're in the intracranial circulation, and that gives off the PCOM as well as the anterocoroidal. And just for completeness, I think it's important to at least just mention that there are persistent fetal vessels that, so when we're born and the immature intracranial circulation is developing, the carotid and vertebral circulation are actually anastomotic at 4 locations at birth, and then over time these anastomoses actually go away and occlude. But at times you can have persistent fetal vessels that do permanently or are always present to connect the carotid and vertebral circulation. So here you can see this is the carotid circulation, the ICA on this picture, and here's the vertebral artery going through the vertebral foramina. And there's four primarily named persistent fetal vessels. 1 is the persistent trigeminal, 2 is the persistent hypoglossal, the proatlantal, and the otic. And the main risk factors here are sometimes there's increased risk of stroke, there can be an increased risk of aneurysm formation, and ultimately this anomalous flow just leads to increased turbulence, posing increased risk of vascular malformations in these patients. This is a nice schematic of what the classic cervical bolus looks like. So as you can see, it's primarily formed by 6 vessels. The ACAs running anterior, PCAs here coming from the posterior circulation, the anterior circulation. This is the MCA vessels coming out at us, as well as the basilar trunk here, giving off the posterior circulation P1s. And so interestingly, the classic circle of Willis is balanced only in 18% of cases. And so oftentimes you will see, typically you'll see a dominant or a dominant posterior circulation artery, posterior cerebral artery, and or a dominant anterior cerebral artery. As noted, the majority of the circle is never balanced in cases. Here's another kind of cartoon rendition of the same thing. So here's the basilar running up the brainstem, giving off the posterior cerebral arteries. This here's here are the ACAs, or the anterior cerebral arteries, and here's the ICA giving off the middle cerebral arteries. And here's a CTA of the circle of Willis as well, and over the next few pictures you're going to see it zoomed in more and more, which is a nice view of what's going on. So this is kind of more of a macro view, and then as we zoom in here, you can kind of see the same thing. So here's the paired vertebral arteries coming up from the neck. It's forming the basilar through the basilar trunk, and at the basilar apex, right near the pontine medullary junction, you give off these 2 posterior cerebral arteries. And then in the anterior circulation here, you can see the 2 anterior cerebral arteries running right along the floor of the cribriform plate. And same thing, the internal cerebral arteries runs up and gives off the anterior cerebral artery and the middle cerebral artery, which ultimately supplies the bilateral temporal lobes. And you'll see it here in a little more zoomed up view. So here's the ICA coming up, giving off the MCA out laterally, and then giving off the ACAs anteriorly into the anterior fossa. So now I think let's kind of go through first focusing on the anterior circulation, and then subsequently focusing on the posterior circulation, but actually going through these named vessels and understanding their circulation, understanding the stroke syndrome that they can cause if occluded, and then also understanding the anatomy that they supply. So here's the middle cerebral artery, and typically the middle cerebral artery will have 4, sometimes they say 4 or 5 segments, but so typically you have the horizontal segment, the genu where the MCA curves up, and then the 2 is it. So we know the middle cerebral artery also gives us the lateral lenticular striates, and then 3 goes into the sylvian fissure, 4 is in the dips of the sylvian fissure, and then it also gives off branches to the insula. So here's a nice schematic view of the inferior view of the brain. And you can see here, this is the middle cerebral artery. So here it gives off some of the lateral lenticular striates, but then ultimately goes out into the hemispheres of the brain. And as noted, so the lateral lenticular striate vessels, they supply three primarily the deep grade nucleus of the brain. So things like the basal ganglia, the internal capsule, as well as the caudate nucleus. And this is a nice picture of the lateral lenticular striate. So here you can see, this is the internal carotid artery within the cavernous sinus. As it comes out, it gives off the middle cerebral artery here. And you can see in the early branches, these are the lateral lenticular striates supplying the caudate, basal ganglia, and some of those deep gray matter structures. And then it'll continue on out here peripherally going into the parietal lobe. And so here's a nice kind of a deeper branch, obviously much more detailed view, but looking at primarily demonstrating how the MCA supplies the insula and kind of some of those deeper areas. And then now when we talk about stroke syndromes, so there's four primarily stroke syndromes that are based on the middle cerebral artery. And the syndromes primarily come from the location of the stroke. And so obviously our most devastating stroke syndrome is where you have complete MCA occlusion. And as we know, if it's dominant versus non-dominant, you're going to get different set of deficits. So in terms of anatomic location, if it's frontal, parietal, lateral, temporal lobes, clinical findings include contralateral facial weakness, sensory loss, hematus hemianopsia, ipsilateral gaze preference, and global aphasia. And so typically, as we know, the left side of the brain is the dominant side. So if you have a left MCA stroke, which is a dominant hemisphere stroke, you'll have right-sided weakness, aphasia, and then hemi-neglect or right-sided neglect. Versus if you have right-sided hemispheric stroke, you'll preserve speech, but you'll have left-sided weakness or left-sided plegia and left-sided hemi-neglect. A named syndrome is Gerstmann syndrome. So oftentimes, so if you have strokes in the dominant inferior parietal lobules, so the angular and superior temporal gyri, this can cause a Gerstmann syndrome where, as I said, it's only for the dominant parietal lobe. So you get an acalcula, right-left confusion, finger agnosia, and agraphia. It's actually pretty interesting. If you have them put their hand into a bag and try and basically decide what item is inside the bag, they actually won't be able to determine if it's a key or a button. So it's pretty easily be able to discern that. I think with MCA syndromes, it's important to understand aphasia. And aphasia is broken down into numerous ways, but I think of it as basically three primary components. So fluency, comprehension, and repetition. And based on the aphasia that you have, different aspects of this triad are going to be impacted. So if it's more of an anterior or expressive aphasia, so something that's involving Broca's area, you're going to have intact comprehension, but no fluency and no inability to repeat. And if it's in the posterior aspect of Wernicke's aphasia, then you're gonna have fluency, but this word salad essentially. They'll talk, but it's just garbled speech that really you cannot understand. So no comprehension, no repetition. And then kind of as you get kind of deeper into the aphasias, there's conduction aphasia. Of course, as you know, global aphasia, so all three are impacted. Transcortical motor aphasia, so motor aspects of speech, you can think of it as. So comprehension, repetition. And then you have the transcortical sensory aphasia, so aspects of aphasia that require you to sense or understand. So the fluency, repetition, those are what's going to be impacted. Next, focusing on the anterior cerebral arteries. So as we talked about, so the anterior cerebral arteries are branches off the internal cerebral artery, and they supply the anterior cerebral fossa, the anterocranial fossa, and it too has 4 segments. And here you can see it goes into the head of the caudate, it wraps around the corpus callosum, goes around the cingulate gyrus, and it gives off the medial lenticular striates. So middle cerebral artery gives off the lateral lenticular striates, versus anterior cerebral artery gives off the medial lenticular striates. And here's a nice lateral view of the brain. You can see here's the anterior cerebral artery, supplying the frontal lobe, and then supplying over the corpus callosum, over the cingulate gyrus, as well as giving off the medial lenticular striate vessels, which are going to be supplying things like the optic chiasm, the anterior commissure, hypothalamus, the septum pellucidum. And so here, this schematic is primarily meant to show more the middle cerebral arteries, but our middle lenticular striate arteries, which are coming off the MCA, just to compare, just to kind of remember that. So the lateral lenticular striates come off the MCA, and the medial lenticular striates come off the ACAs. And the main syndrome that responsible for the so ACA, if you have an ACA occlusion, which I would say is more rare than ACA occlusion, but an ACA occlusion will cause stroke in the paramedian frontal lobes, parietal lobe, corpus callosum, olfactory bulb, and this is where you get contralateral weakness, sensory apraxia, centralized apraxia, and urinary incontinence, as well as anosmia. Now you're not able to supply the nasal the olfactory bulb. All right, so we've completed the anterior circulation. We talked about coming off the aortic arch, common carotids, branching off with the internal and external carotid arteries. We talked about the internal carotid artery, then going to the brain, branching off into the anterior cerebral and the middle cerebral arteries. And that all makes up essentially the anterior part of the circle of Willis. So now we're going to shift our thoughts and shift our focus onto the posterior fossa, or the posterior circulation. And so, as we mentioned earlier, the posterior circulation is primarily composed of, is supplied by the vertebral arteries, which run through the vertebral foramina of the cervical vertebrae, and they come together to form the basilar. And when the basilar enters, when the vertebral arteries enter and form the basilar, they then will give off the posterior cerebral arteries, then completing the posterior aspect of the circle of Willis. And so this is a lateral view looking at the posterior fossa. So number 1 is the vertebral artery coming with the foramen. 2 or 3 is pica. So the first branch of the vertebral artery before it becomes the basilar is pica, or posterior inferior cerebellar artery. 4 is the basilar, and then 5 is the anterior inferior cerebellar artery, and then 7 you can see is the superior cerebral artery, and then 8 is the PCA, or posterior cerebral artery. And so here's an AP view with similar schematic, but here you can see clearly the 2 vertebral arteries coming up, forming the basilar, and at the top of the basilar giving off the posterior cerebral arteries, which then will anastomose or connect into the anterior circulation through the posterior communicating artery. So this is kind of another sketch, but I think it's just another way to illustrate, looking more specifically at the superior cerebellar artery as well as the posterior inferior cerebral artery. So this down here, number one is pica, or the posterior inferior cerebral artery, and number 9 is going to be the SCA, or the superior cerebral artery. Here's a cartoon rendition of the same thing, which I think is helpful as well. So this down here is pica. This up here is the SCA, and then the very top of the basilar is going to be the PCA. And you can see here, just to kind of start thinking about it. So the PCA is going to be supplying your occipital lobes, and your SCA is supplying the superior cerebellum. There's an AP MRA view of the vert injection of a vert as well. So vertebral arteries, basilar, something similar there. Again, this is a cartoon demonstration of the posterior circulation. And here's another picture there. So this is I think this is a helpful one to start kind of thinking about as well. But so this is a lateral view of the brain, looking at the PCAs and how you can see 6, looking at the branches of the posterior cerebral artery, and 6 goes essentially going right to the calcarean fissure. 7 and 8 being the calcarean artery, and 7 being the parietal occipital artery. And so you can see here, it truly supplies the posterior aspect of the brain, and really none of the anterior circulation at all. Okay. So as mentioned, so just like in the anterior circulation, the PCA also has named segments. There's the P1, P2, which has an anterior and posterior, as well as P3 and P4. P1 primarily supplies the thalamus, hypothalamus, kind of the posterior aspect of the deep gray nuclei. Versus P2 is going to be broken up into a P2 anterior and P2 posterior, which supplies kind of more, I guess, deeper, more ventral aspects of the deep grade nuclei. And the P3, as mentioned, is kind of the more distal branches supplying the parietal occipital fissure, calcarine fissure, splenial artery, which gives off to the occipital or the visual cortex. Here's a cartoon schematic, and here you can see the highlighted lobe that's being supplied by the posterior cerebral arteries. And then in terms of stroke syndrome, so the PCA is interesting in that you can have both unilateral as well as bilateral PCA strokes. Unilateral being a stroke that occurs typically distal to the basilar, and then a bilateral PCA stroke, which typically occurs proximal to the basilar, or right at the top of the basilar, perhaps. So in unilateral PCA strokes, there's 5 different types. One is primarily an occipital lobe. 2 is in the dominant occipital lobe, including the splenium. 3 is in the ventral occipital cortex, or in the infracochlear area. 4 is optic radiations, and then 5 is Meyer's loop. So think of it as, so in the occipital lobe, as if it's in the occipital lobe, then we know contralateral homonymous hemianopsia. That's for sure. And then in terms of if it's in the dominant occipital lobe that includes the splenium, then you also have alexia with agraphia. So this is very interesting in that they can read, but they cannot write. And that's primarily coming from the splenium, the corpus callosum, in terms of picking up the, being able to read but not write. And then in terms of the optic radiation, so optic radiation going through is high, going through the parietal lobe, and Meyer's loop is primarily in the temporal lobe. So I always think of it as if the radiations are in the parietal lobe, it's affecting the inferior quadrant, high in the brain, low in the eye, versus Meyer's loop is temporal lobe, which is inferior to the parietal lobe, so low in the brain, then high in the eye, so it's affecting the superior quadrant. In terms of if it's a bilateral PCA stroke, so you can obviously get cortical blindness, so both visual cortices are completely affected. And then you can also get Anton syndrome. It's probably quite rare, but you get primarily visual hallucinations. And then just for completeness, as we kind of, I think it's the last slide, but just to wrap up, but to not forget the venous drainage. And I'm not really going to go much deeper into this, but just to understand, obviously we know there's arterial supply that causes stroke, but also to understand there is good venous return. And venous strokes are another etiology of stroke. And so, we have superior cerebral veins, you have the middle cerebral vein, and then ultimately things flow into the transverse sinus, sigmoid sinus, going to the jugular. So here's a nice drawing here. Superior sagittal sinus, inferior sagittal sinus will then feed into the straight sinus. And as mentioned, all of that will go transverse sinus, sigmoid, into the jugular vein. I think that comes to the end, but can kind of open the floor, open the chat box to questions.